Okay, in this recording, we're going to be covering response to patients' personal and physical needs. All right, so you have some objectives here. Make sure that you're able to answer all the objectives. And you have some key terms that you're going to have to be able to know in order to do well on your quiz. So, personal concerns of the patient. So a lot of the patients when they come in to see us are very anxious. There's something wrong and we are looking at the patient to try to find what the problem is. So with that, patients come in with a lot of anxiety, okay? It may be caused by fears about the diagnosis that we're about to find, the pathology that's within the patient, how this illness is going to affect their family, and also concerns of modesty. So reassurance is provided by the professional touch and attitude details of the procedure. So make sure you explain what you're going to be doing. A lot of it is from the unknown. So if you tell them, this exam is going to take 15 minutes. This is what I'm going to be doing. You are going to be hearing loud noises if you're going into the MRI machine. I'll be talking to you in between sequences. It's really important you hold still. That way we can get through it the fastest that we can. If it's for KUB, I'm going to have you lay on the table. You're just going to hold very still and I'm going to take a couple pictures of your abdomen. So explain to them what's going to be happening and how long it's going to take for the results. Okay, so physiological needs, we need water and we need to go to the restroom. So our bodily functions are, we can't survive without water and we have to be able to eliminate what's inside of us. So water, make sure before you give the patient any water. So if you're in a hospital setting, you cannot give water without checking the chart. So you have to make sure that the patient is able to have water. Sometimes they can't have water because they have surgery the next day. Sometimes they can't have water because they aspirate it into their lungs. Sometimes it's easier for patients to drink with the straw if they can have water, especially if they've had a stroke. A lot of the water will spill out the side that has paralysis. And if you are going to give water, make sure you record the amount of water that you're going to be giving the patient. So I gave a patient an 8-ounce glass of water at this time so that they know. So it's in the chart documented. Elimination. So ask the patient if the restroom is needed before beginning any exam. So never fails. You bring a patient back and they're like, oh, I have to use the restroom. Like, oh my word. So make sure you ask them before you get them changed. Listen, go ahead and get changed, or before you get changed, there's a restroom right here. Make sure that you use the restroom before you come back. I'm going to have you for about an hour, so it's really important that you use the restroom before you come back and see us. All right, so if the patient needs assistance, please provide that assistance. Show them where the call light is. Make sure that they have everything that they need in the restroom so that they don't pass out or injure themselves or in there screaming and yelling. So if the patient is not able to go to the restroom, you need to provide a urinal or bedpan. Make sure that you use gloves. I don't know why here it says sterile gloves, but if you're inserting a catheter, you're going to need sterile gloves. But if you are just providing a urinal or bedpan, you do not need sterile gloves. You just need gloves on to protect yourself. So check the chart for any special instructions. And a specific collection container has sometimes numbers on them. So if you're giving them a urinal, it'll tell you after they use it how much urine is in there. And a lot of times I'll take the urine, I'll close it, I'll record how much urine, 100 cc's of urine, and I'll send it back with the patient to the nurse so that they can run any labs or anything else that they need a urine sample of some sort. So in the chart, you're going to record how much went in, and how much they drank, and how much came out. Okay? So some patients may have a urinary catheter in place. There's a collection bag that is kept with that, and it needs to be below the bladder. So some patients have a colostomy or ileostomy, and you have to provide care for that. And in your book, it shows you how to do that. A lot of the times we don't mess with those. A nurse will come in or a doctor will do it. Sometimes they'll say, go ahead and apply new tape or a new colostomy bag. And you need to know from supply how to get that, okay? And it's real easy. You just peel off the tape and you stick it on. Easy, easy. Make sure that women, after they have a hysterosalpingogram and HSG, sometimes they may need a sanitary napkin. Make sure that you have tampons, pads, whatever that they need, just for the general public, and know where they're stored. All right, positioning for safety and comfort. So we're going to look at body positions and support and padding. Now, putting patients in different positions for comfort works great, but if it's not the position that you need to get your exam done, you're going to have to think outside the box on how to get that patient comfortable so that you are able to get your exam done. And a lot of the times we use padding and support under the knees. So some of the some of the positions that we put the patients in. So recumbent means just lying down. Okay, so recumbent, supine. Great. So we're going to say they're laying down on their back. So as you can see, we have the patient laying on their back in A. Prone is laying on their stomach. And then we have lateral. So it can be in a right lateral or a left lateral. This is a left lateral, so you can have them lay in the lateral position. And then there's Sims position. So that is laying on their side with their leg up and their arms supporting them. So they're in like a 45-degree oblique. Now we use Sim position when we're doing any kind of insertion of a barium tip, or this is a good position for looking for barium within the stomach. So Sims. There's Fowler's position, which is sitting semi-upright and on a gurney. So sitting them up basically as erect as you can is called Fowler's. If they're in a semi-Fowler's, that means they're at about a 45-degree angle. Then we have Trendelenburg, and that's where the head is lower than the feet. So if a patient is going into shock, we will put this patient in Trendelenburg to get the blood to the brain. That's the most important part. And then there's the knee to chest, which is your H, and there's the lithotomy, which has the legs up in a stirrup. So support and padding. So we use a lot of different pads to get the patient into positions and pads to get the patient comfortable in positions. So please do use a table pad if there's a table pad. Please do use a knee bolster for the knees. For patients, it really takes a lot of stress off their lower back. So in X-ray and MRI, we can use these knee pads. A lot of the times, if I don't have one of these pads, I'll just take a couple pillows. I'll lift their legs up and I'll put the pillows under their knees to take the pressure off their back. So that way they can lay still longer. All right, considerations for the elderly and debilitated patients. So they're at an increased fall risk, so you got to be careful with them. And they have a decreased subcutaneous fat layer, so it's like skin to bone and skin to muscle to bone. There's no extra fat layer in there to protect them. And their skin breaks down. It gets really, really fragile. So if you're sliding a patient over to a table from the gurney, patients get skin tears really, really easy, so be careful. I like to burrito roll my patients in their sheet. So if they're on a gurney, I'll take the sheet and I'll wrap it up into the middle so it's real taut, and I'll slide them over so that their skin is protected as I slide them over. Still doesn't alleviate a skin tear. If it's a substantial skin tear, you need to do an incident report and you need to chart that. All right, restraints and immobilization. So restraints are used to ensure patient safety, and it's required to have a physician's order. So very, very serious. If they order restraints, they have to be checked, I think, every 30 minutes and signed off. So if you have a patient who comes down with restraints, it'll be sent down with a restraint order that needs to be signed by you, that there's still circulation and the patient's not injured by them. And then there's immobilization. We help to secure and stabilize to prevent motion. So we have different immobilization devices, and you have to be really careful on your immobilization devices that it's not considered a restraint. With a restraint, you have to have a physician's order. So with immobilization, they're still able to move, but you're there to protect them. So they can't like jump off your table. They can't, you will have time to respond to protect them without restraints. So It's a fine line, so be careful with that. Using Velcro, they're usually okay with that because the patient can break free from the Velcro, so it's not considered a restraint. But depends on the type of Velcro, where the Velcro is applied, all the above. Be careful. All right, observation of signs of abuse. So child abuse. So it's also termed battered child syndrome or non-accidental trauma. So you'll see NAT come through quite a bit from the ER. So you got to watch for that. We're looking for some kind of trauma to this kid that would not be normal for the accident in which they're claiming. Okay, so if you see a lot of bruises, a lot of healing fractures, um, just weird stuff, pay attention because we're looking for that. Usually if they come in through the ER, we're already aware, and the ER is already aware and is already calling everyone that needs to come in and evaluate. But if they're coming to you as an outpatient and it's just not adding up. So they said they fell off the monkey bars, but they have weird bruises all over their body and they have old healed fractures. Um, Pay attention to that. Let your tech know, let your supervisor know that something's not adding up with this case, and they'll call someone out to check on the child and make sure that they're safe in their environment. Now, elder abuse is a whole nother ballgame. A lot of elderly are abused physically and emotionally. So I've seen it a few times where they come in and someone will walk in and all of a sudden you'll see their blood pressure go up and their heart rate go up. And you're like, oh, well, that's interesting. And so you'll notice that they look out of the corner of their eye at the person and is afraid to make eye contact. And every time they walk up, they kind of lean away. And so pay attention to those signs. Let your tech know, let your supervisor or lead know, let the ER physician, whatever, whoever, and let them know that something's suspicious with this case. And it's not that you can report it. They have to report the abuse, but you are the first line of defense for that person, okay? All right, so child abuse signs, multiple injuries as evidence of chronic or repeated injury with no other explanation, injuries that are not consistent with the patient's report of the trauma, failure to seek prompt treatment for serious injuries, bruise marks shaped like hands, fingers, or objects such as the belt, specific patterns of scalding, burns on hands and buttocks, cigarette burns on exposed areas or genitals. So that is the saddest thing I've ever seen is burn marks on little boys. It's just the saddest thing ever. Black eyes in an infant, human bite marks, lash marks, choke marks around the neck, circular marks around the wrists and ankles from twisting, separated skull fractures or bulging fontanelles in an infant. So watch for those if you're doing an x-ray. Unexposed unconsciousness of an infant. So a lot of these are going to come to you, and we already know that this child was abused, so just be cognizant of who's in the room with you and careful what you say. All right, so elder abuse, and we're looking for bruises, pressure marks, broken bones, abrasions, or burns that may indicate physical abuse, neglect, or mistreatment, unexplained withdrawal from normal activities such as sudden changes in alertness, an unusual depression that may be indicators of emotional abuse. Bruises around the breast or genitals areas can occur from sexual abuse. All right. So, sudden changes in financial situation may be the result of elder abuse, decubitus ulcers from unattended medical needs, poor hygiene, and unusual weight loss are indicators of possible neglect. Behaviors such as belittling, threats, or other uses of power and control by the spouse are indicators of verbal or emotional abuse. Strained or tense relationships and frequent arguments between caregivers and elderly persons are also signs of elderly abuse. So just pay attention, be on your toes, do what you can to protect the patients, whether it's elderly, whether it's a child, whether it's a husband or a wife. Husbands get abused by women, by their wives. So just be on alert, and your job is to let your tech and let your manager know that you suspect something that just doesn't seem right. Okay? that is your lecture.